I'm excited to welcome Dr. Maxwell. Dr. Maxwell is a pediatric cardiologist who has spent years helping patients understand the complex connections between the autonomic nervous system, connective tissue disorders, inflammation, and so on. His work has encouraged many patients and clinicians to think differently about symptoms that are often treated as separate problems rather than pieces of a larger puzzle. As someone who lives with dysautonomia, HEDS, CSF leaks, I'm especially grateful for this conversation. So today we will be discussing Dr. Maxwell's work, especially the theory of spiky leaky syndrome. And Dr. Maxwell, thank you so much for being here. I appreciate you. Please tell us a little bit more about you.
I was a medical student at Johns Hopkins back in a few decades ago, and then trained at UCSF in pediatrics in San Francisco, and then followed that with training at Stanford in pediatric cardiology, and then followed that with some research, basic science research in vascular physiology. So got to really know the vascular and the autonomic nervous system really well at the benchtop. And then started my practice in pediatric cardiology about 25 years ago. And along the way, started seeing a lot of patients with dysautonomia, and realized a lot of those patients had, hypermobility, and oftentimes ended up acting like a patient that had mast cell activation syndrome. So I looked into that. That was about a decade ago at this point, and met Larry Afrin and really put together the theory that there was this triad, and kind of expanded that to say, the GI tract is so important here, even though it's kind of a consequence of the triad. It's so important here. It deserves its own, as well as kind of the immune system being so dysfunctional deserves its own. So we started calling it the pentad. And so that's where this concept of the pentad patient kind of arose, the patient that had dysfunction of the autonomic nervous system, evidence of mast cell activation, evidence of hypermobility, really bad GI motility, and evidence of various forms of immune dysfunction.
Wow. Is there anything that, like, in the beginning that ultimately drew you to this? Was it like just seeing a whole bunch of patients at once?
No, I mean, it was very, very progressive where, first I think it was trying to understand these patients who had orthostatic intolerance and couldn't really find anything wrong with their heart. Again and again, it was like there was no evidence of cardiac dysfunction in any way with these patients that were orthostatic intolerant. And so that started to open my eyes to this idea of dysautonomia, dysfunction of the parasympathetic nervous system with potential sympathetic overdrive that kind of explained all their symptoms. It's like, okay, last thing that's wrong with you is your heart. And even though I'm a cardiologist, I'm going to help you because no one else seems to be able to. And so it really was the basis for me beginning to understand how the parasympathetic nervous system was affecting the vascular system and the heart itself, but then of course more broadly the entire body. And somewhere along the way, some of these more complex, sicker, chronically ill patients started to show signs that they had increased intracranial pressure and CSF leaks. And for a good amount of a few years, sending these patients to the CSF leak doctors and not really getting any answers that they were leaking anywhere in their spinal column. And what it seemed to be is that a lot of them were dribbling CSF out of their nose and places like that. And so that's where the theory of spiky leaky began to be formed.
Absolutely. Is there, are you able to tell us more about spiky leaky syndrome? What would the patients kind of look for? How would they be able to tell themselves that they might have this, and a little bit more about it?
No. Well, we studied, we went back retrospectively and looked at last 100 patients that actually met full POTS criteria. So the heart rate rise. And so we wanted to look at dysautonomia patients, but only the dysautonomia patients that had some form of objective measurement. And that is usually best if you're sticking with those who are meeting POTS criteria. And we had to look at about 400 dysautonomia patients to find 100 that met the POTS criteria. So even POTS itself is just a minor, 25% of the greater dysautonomia population that I've seen. And of those 100 POTS patients, most of them had mast cell activation syndrome, and many of them had hypermobility. And so if you looked at the triad of those patients that had all three of those things, at least 15% of those patients had elements of spiky leaky. Now, it may have not been the full-blown spiky leaky, but it was showing that they had the elements that would be set up to progress towards spiky leaky. And so that would be those who showed what's called craniocervical instability, and those who may be actually showing evidence of airway obstruction at night, so that they would retain CO2 when they were sleeping at night. And those were the main elements. So at least 15% of those patients that have hypermobility, mast cell, and dysautonomia were showing cranial cervical instability and evidence of airway loss at night, so they're retaining CO2. And those are basically the setup for moving on towards spiking your CSF pressure and eventually leaking it.
Do you believe that, I know a lot of people, in the community, they'll get tested for MCAS, they'll get tested for hypermobility and other things, and it won't show up on like test results. What are your thoughts? Like if people are like, I know I have this, I know I have something going on maybe with the CSF leak. Do you have any ideas or things to say to them?
Yeah, well, each one of those need to be taken separately. Mast cell is a very difficult thing to objectively show. And over the years, I've kind of shortcutted the process to basically saying, hey, if you're hypermobile and if you're dysautonomic, it is worth a trial of mast cell medications. And so you may have heard of consensus 1 and consensus 2 criteria for mast cell activation. And so this is almost consensus 3 criteria. Consensus 1 is, the old-fashioned criteria whereby you need to have a tryptase elevation, and it's even more complicated than that. You have to have a tryptase elevation during a flare, and no elevation when you're not flaring, and then there has to be a certain 20% rise plus 2 between the two values, and it's very, very difficult to meet that criteria, not only logistically, but just the numbers. Most patients do not have a period where they're completely symptom-free, so trying to find a time when they can go get their tryptase measured when they're symptom-free is hard enough. So that's consensus 1, and very few people meet that consensus. Consensus 2 was developed to capture more patients that clearly had a mast cell issue, and that meant it expanded the different laboratories that we looked at: plasma histamine, urine histamine, prostaglandins, chromogranin A. So the list became much longer to look for evidence of release of contents of mast cells. But even that is problematic because these substances are very evanescent. They don't last very long. They require the blood to be drawn into chilled tubes and centrifuged in refrigerated centrifuges. So it's very difficult to even get those testing. And again, it often delayed just trying mast cell suppressing agents. And that's the second part of consensus 2, is the response to mast cell suppressing agents. So consensus 2 fully would be elevation of some sort of marker, as well as response to mast cell activation suppression Well, mine, what I would call consensus 3 perhaps, is just, well, let's just go ahead and give mast cell suppressing agents. And I typically use a combination of H1 and H2 blockers and mast cell stabilizers and give a really good go at it. And if they respond, then they have mast cell activation syndrome. And what we found, about 85% of patients who had who had full-blown POTS had a very positive response to just suppressing mast cells. So that is my definition of mast cell activation present. We wrote a paper on this, the 3 different definitions of mast cell, and how the frequency is determined by your definition. So the same issue exists with hypermobility, because there is no biologic marker for Ehlers-Danlos, hypermobile EDS. It's a clinically driven assessment and definition. And there's a lot of parts to that definition that are apply to some people but don't apply to others. So, the 2017 criteria came out, and a lot of people have problems with it because it's based on consensus. It's not based on biology. And if you look at a lot of the details, for instance, an entire major criteria is whether another person in the family, first degree relative, has been diagnosed formally or not. And so, if you have a de novo, or if you're the first in the family, then suddenly you're at a big setback for not being able to meet that criteria. And likewise, the same is true for young people. A lot of these things develop over time. Prolapsing of organs develops over time. And so if you're a young person, you're having a challenge meeting this criteria. And that's on top of the criteria being almost completely arbitrary, based on, again, a consensus of experts who kind of all agreed to add and not add criteria. So a lot of us have, developed this concept of, nearly meeting hypermobile EDS criteria, nearly meeting this 2007 criteria. Quite frankly, some of us are saying, there is no difference between a person who has met hypermobility syndrome and those who meet hypermobile EDS, and that we should quit, trying to separate and parse out the two. We should quit thinking that one is worse than the other and deserving more attention and more care than the other. And we should just start trying to define those who meet hypermobility syndrome and not specifically call them hypermobile EDS patients. So that needs to be addressed. So it is difficult for patients to be going around getting these diagnoses. And I've always had the position that I'm not sure the real relevance of being labeled as having mast cell and being labeled as having hypermobile EDS, and certainly being labeled as having POTS. A lot of people seek these diagnoses that want to be labeled as them, and they may have their reasons for doing so. Getting the other people in their lives to understand that they have an illness. So if they have that label given to them by the doctor, then it's maybe easier for other people to understand in their life, or their teachers to understand.